Right, good afternoon, ladies and gentlemen. I'm going to struggle trying to grab your attention after the lunchtime slots. I'm very honoured from the BMI to give me this opportunity. So this is a question that a lot of you guys probably get. Doctor, my knee hurts. My name is Joyti Saksena. I'm an orthopaedic consultant at the Royal Free Hospitals, mainly at Barnet Chase Farm. So we're going to sort of run through a general kind of scheme today, how to really make the diagnosis, how you guys can manage these patients in the community, when to refer, what are the indications, when are the right times to refer, and then what can your patients expect from us. I've got a couple of cases that I can go through just to try and help cement things, and then a few take-home messages at the end just to try and get you on your way. So really, how to make the diagnosis. The main decision we need to make is when a patient comes in with knee pain, doesn't matter who they are, what their age group is, try and determine whether this is an acute problem. Is this an acute injury? Did it happen recently? Is there very immediate sort of pain, swelling, discomfort? Or is this more of a chronic, it's been going on a few years, gradually getting worse, gradually limited with what they can do? If it is acute, you need to really find out in their history what happened, the exact mechanism, when it happened, how it happened. And these really give you clues to the diagnosis. And just trying to work out the mechanism, whether it's a twisting injury, whether it was a fall from a height, whether it was a stud stuck in the ground and then the momentum of the body carried on, those kind of things will give you a clue as to what the diagnosis is. And always think about potential fractures. Sometimes you get very subtle fractures around the knee, avulsions, small tibial plateau fractures that sometimes are even missed on plain x-rays, and it's useful to keep that in the back of your memory. With the chronic symptoms, the chronic sort of history, it's really the history of the pain, the type of pain. Is it sharp? Is it dull? Where does it arise from? Where does it travel to? What things make it better and what things, aggravate it. And a functional history is really useful. Can they go upstairs? Can they put on shoes and socks? Can they drive a car? Can they sort of get in and out the bath? And these kind of questions will help determine whether this patient is managing or on that cusp where they may not be managing. And sometimes you can get a combination of the two, the kind of so-called acute and chronic injuries, typically where you see patients with arthritis and they've been managing for so long, they've not really complained, and then suddenly they have a trivial fall or something, and that really aggravates their symptoms. So with the acute injuries, one has to always think of soft tissue injuries. Think of the meniscus, the ligaments, the tendons around the knee, muscular strains and pulls, and also chondral defects that affect the actual articular cartilage, which are not obviously apparent on x-rays, and sometimes even on early MRI scans may not be absolutely apparent, but will cause severe pain, swelling, discomfort. And with the chronic injuries, it's really the main kind of obvious diagnosis is osteoarthritis, but there can be other things, osteonecrosis, rheumatoid arthritis, and sometimes patients complain of pain in the knee, and the pain is often being referred from the hip, so it's always useful when you come onto the examination to always examine the joint above and below. Moving on to the examination, the first thing to do as the patient comes into your clinic room, into your practice room, is to always look at how they're walking. The gait often gives you telltale signs as to whether patients are managing or not. And typically in the arthritic knee, you may see things like a varus thrust, where there's actually the knee kind of almost subluxates every time they walk. The antalgic gait tells you that this is an acutely painful, and that's where you get a shortened stance phase. It's almost like walking with a stone or a pin in your shoe. You spend little time on that leg. And the stiff knee gait, which is typical in some patients with locked knee or with indeed severe arthritis where bending causes pain. When you examine the patient, you need to fully undress them, make sure that you're looking at the whole alignment, and it's very obvious to see things like fixed flexion deformities, or indeed patients that are holding their knee in a bent position because they can't fully straighten it. You want to check for things like swelling, and that tells you whether there's an inflammatory process going on, Obviously, in the acute situation, any signs of bruising. You then want to go on to move. Get the patient to, first of all, move themselves. What can they do themselves? And then what can you do for them? And so you're trying to assess the passive and the active movement separately. And generally, you may find that if there's a difference between the two, then that can give you, again, telltale signs that there may be something going on. You want to assess their range of movement, assess for fixed flexion deformities, and that's typical in arthritis when they start to get capsular contractures at the back of the knee starts to bend and it stays in that position and they can't fully straighten it. When they can't fully straighten it, they're effectively firing their quadriceps all the time, and they often will then show signs of muscle wasting or fatigue, or their exercise tolerance becomes, significantly reduced. Always stress the ligaments to know if there's any incompetencies there. And particularly the special test for the acute injuries of the McMurray's test, which we use to try and provoke the meniscus, to try and catch it between the tibia and femur to see if that causes any pain or discomfort. And even if that's not possible, simply getting the patient just to squat down. If they can do a deep squat, that generally tells you that their tibiofemoral, their joint, is probably okay. If it's causing pain or they're unable to do a full squat, then that often suggests that there may be something catching, something locking, something sort of caught between the two bones. The anterior draw test is very useful for the cruciate ligament injuries, and it's literally pulling the tibia on the femur to see if there's any excessive translation. And sometimes it's difficult to tell, but generally patients will have a good knee to compare with. Sometimes they don't, but it's useful to compare the two sides to see if there is any difference. And often the difference is more important than necessarily finding things. Moving on to the investigations. Time and time again, we'll often see patients being referred with just an MRI. It seems to be the investigation of choice, the investigation that picks up everything. But don't forget the plain films, the plain weight-bearing X-ray, and it should be weight-bearing to typically assess the sort of tibiofemoral joint. And also include a skyline view of the patella, and that really gives you information about the patellofemoral joint, which is not always apparent on the lateral X-rays. And without that, really, most orthopedic surgeons will always request it, so it may as well be something that you do, and just make sure it's weight-bearing. With the MRI is useful, but it becomes so sensitive that even in sometimes normal patients, you can do an MRI and pick things up, and then you don't know whether it's an actual problem or just a red herring. But typically for soft tissue injuries, anything to do with ligaments, tendons, meniscus, then it can pick it up. But don't forget, MRIs are still only 95, 98% sensitive. And although you order it, you typically get reports which are not necessarily done by musculoskeletal radiologists, and therefore doesn't always correlate with the patient's symptoms. So you've always got to bring it back to what the patient complains of and what the MRI shows. But it can pick up things like subtle fractures, bone bruising, which would suggest that there is some kind of significant injury going on. CT scan is also underutilized. It gives you a three-dimensional X-ray. It's very useful if typically a patient has trouble to weight bear or having sort of difficulty. And you can often assess other joints at the time. If you're looking at the hip joint, ankle joint, you can do 3D reconstructions and look at overall alignment. It picks up things like fractures, avulsion injuries, and other investigations such as bone scans and arthrograms are probably not as common practice in the community setting, but can sometimes pick up things if you're really not sure, and it can focus the problems into a certain area. Also can pick up referred problems, typically in hip and knee arthritis. When you're making the diagnosis, obviously that's the key to managing patients. Without a diagnosis, it's very difficult to obviously treat. But you can, there are some helpful things, looking at the patient's age and trying to sort of lump diagnosis with age can sometimes help narrow things down. Typically in the pediatric or the young adolescent population, things like Osgood-Schlatter's, which is where you get there's a mismatch in the bone growing and the tendons growing, and they get this typical sort of bony lump appearance on the front of their tibia. Tendinitis, subtle tendinitis in the patella tendon, quadriceps tendon, often hamstring tendons can be picked up. And also small fractures that typically, people don't, patients don't often complain of. They can get picked up quite easily. In the adults, you want to think of the meniscus, the ligaments, the tendons, and the chondral surfaces. Those are the key areas where typically injuries occur. And you've got to go with the percentage game. The common things generally occur commonly. And in the elderly, osteoarthritis, osteonecrosis, where you effectively get part of the bone losing blood supply, which causes an obvious appearance on the x-rays and MRI. Things like fractures and also referred pain, those are the key kind of diagnoses to think about. Now we go on to management. Management within the community setting in primary care. I'm sure this is going to be a little bit of repetition, things that you already do, but it's sometimes useful to kind of rethink about what the patient really wants. And often it's not always that they need a second opinion or they want a referral, but generally getting the patient to manage their condition, making them understand, making them feel empowered that, to go and find information about whatever their diagnosis that you kind of discover, getting patient information leaflets. Obviously, most people are internet savvy these days, and there's lots of websites people can use to try and get more information. And if they get more information about their condition, it kind of helps you to sometimes make a diagnosis, and it helps them to manage the condition. In terms of the acute pain, the acute knee injuries that come in, generally it's activity reduction, resting it. We use the acronym RICE, rest, ice, compression, elevation, and those are generally what you do for the acute swollen knee. With the arthritic conditions, things like weight loss, hot and cold packs, these are all ways of sort of managing it themselves, and often they may have even tried it, or sometimes just by suggesting it can help. Joint supplements is slightly controversial. If you go to NICE guidelines, they won't overly recommend it because of sort of cost versus benefits. But there are some studies which show that simple things like glucosamine, chondroitin, cod liver oil, these kind of medications, certainly in the early arthritis, can help preserve the joint and delay the onset of arthritis, which may need joint replacement surgery. Walking aids is really underutilized, and often people don't like them. They have a fear about using walking aids because of what other people say. But literally, if you've got a patient with an arthritic knee and you use a stick or a cane in the opposite hand, you're reducing the weight through that painful leg by 50%, and that can make a significant difference just to their quality. And even if it's in the acute sort of scenario in the first few weeks, it can significantly help them. Other things like gels and creams, topical treatments, these kind of things can help. Analgesia is a huge kind of talk in itself, but generally we use a kind of analgesic ladder, starting with the simple things that you guys all use, paracetamol, add in an anti-inflammatory if they can take it, and then going on to the stronger sort of codeine-based preparations, tramadol, and then eventually you can, if people are in that much pain, ideally at that time you'd be referring them, but people, if you're managing them and they simply don't want surgery, then things like buprenorphine patches, slow release analgesia, these can help manage it. And typically if you go through their sort of pain history, people typically try just one drug after another drug after another drug, but go through their history, identify where the pain is, and often if it's at night time and their quality of life is being affected, that's where to target, to make sure that they're taking those painkillers before they sleep to get a reasonable sleep, and that certainly improves quality of life. And then you may need to look at what their activity is. If they've got particularly active lives, particularly strenuous jobs, they need to be taking that medication regularly, almost taking analgesia before they get the pain to try and get better control. And simply just reviewing their history, reviewing their analgesia requirements can help. Other modalities of treatment, physiotherapy, and that's a whole session which we'll come on to, but physiotherapy can really help in terms of firstly helping support the patient, understanding their problems, helping from a psychological perspective, getting them to grips with their problems, and then obviously strengthening the muscles, working on maintaining range of movement. Even in the arthritic knee where people say, well, I've tried physio, it doesn't work. Actually what physios can bring to the table is making patients understand their condition and help preserve their range of movement that they've got so they don't continue to deteriorate or certainly deteriorate less rapidly. There's also other modalities, things as acupuncture, TENS, ultrasound, and cryotherapy, and all these things can help. And sometimes you don't think of them firsthand in primary care, but these are often treatments that can be tried, can be brought in. Physiotherapists often use them to try and control patients' pain. Functional bracing is also, again, underutilized, typically in a patient with a varus arthritic knee, as the diagram shows. By just pushing that knee into a valgus alignment or into neutral, you can offload the worn out area, and that can significantly reduce the pain and possibly avoid surgery, at least in the short term. So when to refer, I mean, that is the key question. And there are lots of sort of scoring systems, Oxford scores and visual analog scores that people use. None of these are actually designed for that purpose, and therefore you have to use them with a little bit of caution. But generally for me, if in the typical arthritic kind of case, if they've got pain at night, pain at rest, their quality of life is deteriorating, and they've got impaired function, so they're struggling to get in and out of the car, they're struggling to have a bath and tend to have a shower, they're unable to put on shoes and socks very easily. Those functional limitations, those are the key. That's when people or patients generally feel their life is really suddenly deteriorating. That is the time to refer, or ideally just before that, so that they don't get that bad. With the acute injuries, the soft tissue injuries, I think really if the patient is not getting better, you've seen them week on week for 2 or 3 weeks, and there's no real improvement, their knees are still locked, they're not able to fully straighten it, they're still swelling, it's still causing pain, they're struggling with work, then those patients should be referred in early. When not to refer, now this seems pretty obvious, but there is quite a number of occasions where patients come to the clinic, or come to certainly my clinic, and they've got barn door obvious arthritic knee from their history examination, the x-rays confirm it, and then you offer them a knee replacement or a hip replacement, whatever it may be, and they actually don't want surgery. And really that patient, I'm happy to say it's never a problem, but actually one of the key questions is before you're referring to the orthopedic surgeon, always ask them if they actually would consider surgery. Because if they don't, if they're a kind of a person that just doesn't want to consider surgery, then there's little that I can offer than you guys are already doing. And also some patients often come, they haven't gone through that kind of ladder that we've described in terms of functional treatments and physiotherapy, and if they haven't tried that, then there's no point jumping straight to a knee replacement just because they've got a worn out knee. Some people do manage, particularly in that sort of 55, 60-year-old group where they're still potentially working. It's probably not the best thing to do, even though a knee replacement will improve their pain and may improve their mobility. In that kind of working age group, you really want to try and get those people through it until sort of at least potentially retirement or early retirement age, when then their demands on their knee are certainly less. So what can your patients expect? I'll try to purposely keep this to a minimum. From myself and from other orthopedic knee specialists, we would completely review their history, examination, and go through the investigations that you've already ordered. Typically, if they haven't had weight-bearing x-rays, we'll make sure that we get these done. And then we have also the benefit of people with equivocal x-rays or equivocal MRI scans to have MDTs where we discuss with the radiologist. And that's really the main benefit that I think we have in terms of the benefits of our radiology colleagues, where you can examine the patient and try and put the clinical findings with the X-ray or MRI findings, because the two don't always match, and often an MRI will show something like a loose body or a meniscal tear, but actually that's not what the patient's problem is, and it's really important to try and match those two. We'll again give them the sort of the spiel against, operative versus non-operative intervention. And although, my job is to operate and that's what I enjoy doing, there is a real indication, and people who are, the real winners that do well, and some people that no matter what you do, they're not going to do well. And those are the people it's really important to try and get them to understand their condition and try and manage it themselves and with yourselves in primary care. And then decide the appropriate management. In terms of what we do, arthroscopy replacement, most people think of these are the only two things that an orthopedic knee specialist is going to do. But within that sort of gamut, there's a number of things. There's a number of novel techniques for the young adult arthritic knee, cartilage preservation, joint preservation type surgery. So it doesn't mean that they're either going to have an arthroscopy. If that doesn't work, we have to replace it. In between those kind of two extremes, we can do partial knee replacements, we can put in newer bearing surfaces, we can do joint preservation surgery to try and prolong the life of those knees. And there's a number of newer techniques out there which are not always apparent and sometimes is appropriate to your patients that we're treating. So I'll go through a couple of clinical cases, and I'm happy to have any sort of discussion regarding this. So if we've got a 25-year-old male patient, he comes in, he's had a twisting injury a couple of weeks ago. And when you examine him, the patient's got an obvious sort of a knee effusion. A fracture has been excluded. He's been to A&E probably a week before, but he's not able to fully straighten the knee. What kind of thoughts would be going through your mind? Does anyone know? Hazard a guess? Yeah, meniscus. Those are the key things. So someone's got effectively unable to fully straighten a knee means that they've got a locked knee. I mean, you can get unable to fully straighten if they've got a fixed flexion deformity, but we're talking about a young male unlikely to have an arthritic knee. But meniscus has got to be the number one thing. And in terms of meniscus, it's generally, if you're unable to straighten it, it's going to be some kind of tear which is enough to be coming into the joint, either a bucket handle tear or a significant kind of what we call a parrot beak type tear, which is significantly sort of preventing that patient. And sometimes they'll give a history where it does straighten, they kind of jiggle their knee around, it straightens, and then they can go on about. And for that patient, even though you think straight to MRI, you need to make sure that those plain films either have already been done or you would order them just to exclude things like a fracture or a loose body or something like that which can cause it. Okay. Next case, a 55-year-old lady, a 2-year history of painful knees. She's come to you on many occasions. You've treated her with painkillers, physiotherapy. And you've even had some x-rays done, and the x-rays look, weight-bearing x-rays, they look fine. The joint space looks reasonable, and things aren't really adding up. But she describes a history of pain, particularly when she goes downstairs, particularly on, getting out of a low chair when she gets up. And her range of movement is actually quite good, but she has crepitus, this kind of creaking as you straighten the knee throughout the range of movement. What would be going through your mind at this stage? Patellofemoral, yeah, and that's very, very often under-recognized in terms of you do the weight-bearing x-ray, it looks fine. Often people would dismiss them saying no arthritis, go and manage it. But some people have significant patellofemoral changes to enough to be able to account for them to have something like a patellofemoral replacement. And that can really be a beneficial procedure to try and alleviate their pain, but joint preserving, in other words, maintaining their normal ligaments, their normal tibiofemoral joints, and thus actually prolonging the lifespan of the normal joint, but only replacing the part of the knee which is worn. So in summary, the history mechanism is the key. If you can get a really accurate history, how they did it, when they did it, then that often will give you the diagnosis. The weight-bearing x-rays always make sure the weight-bearing include the skyline view. MRI, only already order for a soft tissue. If you're thinking a soft tissue problem, then that's absolutely fine. But other than that, the plain x-rays give you as much information, if not more information. And from my perspective, refer early. If they're in trouble, they're not winning, you're not getting through, then refer early. And by all means, give me a call or send me an email, and I'll be happy to discuss any patients. Thank you very much.